good evening to our honorable faculty and EDIC 1 aspirants. Our today's speaker is Dr. Sankha Subradas. His academic degree includes MBBS, DTCD, MD in medicine, MRCP in UK, FRCP in Edin, DNB, Cardiology, MNAMS. He is a senior consultant in Interventional Cardiologist at Apollo Multi-Speciality Hospital, Kolkata. For now, over to you, sir.
So the topic of today's discussion is pacemaker and implantable cardiac defibrillator. And remember that this is a two-way discussion. And if you have any query or if you have any question, you can ask me during the presentation. So going on to the first slide, pacemaker. So what is a pacemaker? Pacemaker is a electrical pulse generator which can produce electrical impulses inside the heart via leads. It stimulates the heart to create an electrical depolarization with subsequent cardiac contraction. The components of the pacemaker is the pulse generator, then the connecting leads. If it is a single chamber pacemaker, there is a single lead into the right ventricle. If it is a double chamber pacemaker, there is a lead in the right atrium and one lead in the right ventricle. And these are the tip of the leads which contain the cathode and the anode. So, and mostly we position our pacemaker leads in the right side of the heart, that is the right ventricle and the right atrium. Now, how does it stimulate the heart? The leads of the pacemaker. Now, there are two types of leads in the pacemaker, single chamber and double chamber pacemaker. And the leads are basically of two types, unipolar lead and bipolar lead. On the left side, there is a picture of bipolar lead, and on the right side, there is a picture of unipolar lead. In the older times, the pacemakers were mostly the unipolar lead, where the cathode and the anode is positioned. The cathode is positioned at the tip of the lead, and the anode is basically the pulse generator. And there is a flow of electrons from the cathode to the anode, and there is a flow of current from the cathode to the anode. So you can see here the flow of electrons. This is basically the anode, the positive end, and this is basically the cathode, the tip. And you can see the flow of electrons or the flow of current. On the left side, you can see dual in the bipolar type of pacemaker, where the lead is bipolar. The tip of the lead contains the cathode, and this red one, this is the anode. So the cathode and the anode are separated by a small distance if it is a bipolar lead. And if it is a unipolar lead, the cathode is at the tip of the lead, and the anode is basically the battery, the pulse generator. Now, the problem of previous or older generation pacemakers were that there is a long electrical field, large electrical field, starting from the pacemaker up to the tip of the electrode. So there is significant interference by electromagnetic waves or other electrical impulses. So that was the problem of unipolar leads which was used previously. There was a lot of interference in unipolar leads from external vibrations, sounds, and electromagnetic interventions. In cases of the bipolar leads, the cathode and the anode are very closely placed. So the electrical circuit is complete within the tip of the electrode, and so the effect of electromagnetic interference or other sorts of interventions are much less in a bipolar lead. So that is the reason why most of the leads are now bipolar, instead of unipolar. So these are the pacemaker leads. There are two types of pacemaker leads. These are the passive leads of the tine leads, and this is the active leads. The passive leads have, you can see the spikes. These are the spikes at the tip of the passive leads, which fix into the right ventricle muscle. And this is the active lead, where when you rotate the lead, a screw comes out from the lead and it fixes the lead to the right ventricle. So these are the two types of pacemaker leads, passive and the active fixation leads. Now, what is the pacemaker battery? Pacemaker batteries are mostly chemical batteries, and they are basically made up of lithium-ion batteries. Basically, they are lithium-ion batteries. And nowadays, the amount of electricity consumption is much less compared to the older generation of pacemaker batteries. So electrical consumption is much less, and the lifespan of the modern electrical pulse generator are much more longer. So there are two 2.8 volt lithium batteries connected in series to produce a 5.6 volt potential. And normally these batteries generally last average 5 to 10 years. But the modern pacemaker batteries which are used, they can last up to 15 years. Remember, these are lithium-ion batteries. When pacemaker batteries need to be replaced, the entire device is removed from the leads and taken out. So when you do a replacement, it is the battery that is replaced, not the leads. The leads remain the same. It is only the battery that is removed, and a new battery is implanted. What about the leads? The leads are basically titanium alloys or iridium alloys or platinum alloys. So these are basically the leads. And there are often steroid-eluting leads. That means that there is steroid elution from the tip of the leads. Whenever you implant a lead over the surface of the right ventricle, there is a reaction between the pacemaker lead and the local tissue. And the steroid that is eluted from the tip of the lead basically inhibits this tissue reaction. Because if this tissue reaction is significant, there may be problem with capture of the pacemaker. So these are often called steroid-eluting electrodes. The electrodes must be designed so that the power output of the pacemaker is minimized while being able to effectively stimulate the myocardium. So lesser amount of electricity with maximum stimulation of the heart. Decreasing the geometric size of the electrode decreases the amount of charge leaked out into the tissue that does not need to be stimulated. Therefore, less charge is needed for the same effect. So the tip of the electrodes are often made very small so that you generate minimum electricity that is sufficient to create an action potential. So that is the aim. So a geometrically small electrode decreases the power output. Currently, the electrode tips have a surface area less than 1.2 millimeters square. So you can imagine how small is the tip of the electrode. So can anyone tell me that what are these different types of pacemakers? There is one lead here, there is one lead here, there is two leads, one here, and there are three leads, one here, and one here. So anyone from the students? What is A?
Single chamber pacemaker.
Very good, single chamber pacemaker, where the pacemaker lead is positioned to the RV. What is this one?
That is also single chamber, but the lead is.
And where is the lead positioned?
Right atrium, sir.
To the right atrium. What about this one?
Sir, dual chamber with one lead being in right atrium and the other lead being in right ventricle, sir.
Fine, very good. And what about this one? I'll be very happy if you can tell this one.
Sir, Is that a CRT, sir?
Yes, very good. So this is basically, there is a third lead here. You can
Yes,
see
sir.
it was the LV side.
Yes, sir.
So why do you keep this lead? What is the position of the lead?
One is in left ventricle, one is in right ventricle, one is in right atrium, sir.
No.
No, sir.
Now you can't keep a lead inside the left ventricle. You can't. So where is
Okay,
the
sir.
lead basically? Anyone else?
So left atrium at the
No, you can't keep a lead inside the left atrium or left ventricle. Pardon? Huh?
Bundle of his, sir?
It is
Bundle of his?
actually in the coronary sinus.
yes, sir.
The lead is basically inside the coronary sinus. So you can't directly pace the left ventricle. So you have to keep this lead inside the coronary sinus, and this lead is positioned inside the coronary sinus. So that is what happens in CRT, cardiac resynchronization therapy. Okay. So this is a single chamber pacemaker, which is basically a ventricle placed. This is a single chamber pacemaker, atrium based. This is a dual chamber pacemaker, DDDR, and this is a CRT. So what are the indications where you are using a pacemaker? Obviously, to begin with, it is the sinus node dysfunction, sick sinus syndrome, sinus pause, sinus arrest, or the tachybrady syndrome. All these are the part of the sick sinus syndrome. Next comes the AV block. So it could be a second degree AV block, which may be type 1 or type 2. So if it is a MOBIS type 2 AV block, or if it is a complete AV block, it is an indication of putting a pacemaker. The patient can have a bifascicular or a trifascicular heart block. If a patient is symptomatic, having a syncope with bifascicular or trifascicular heart block, it's an indication for pacemaker. Hypersensitive carotid sinus syndrome. Can anyone tell me what is hypersensitive carotid sinus syndrome? Any one of you? No clue? So whenever there is a pressure on the carotid sinus, there is an abrupt fall in blood pressure as well as a decrease in the heart rate. So if there is a significant pause more than 3 seconds during carotid sinus massage and the patient is symptomatic, then it becomes an indication for putting a pacemaker. So hypersensitive carotid sinus. When does the carotid sinus get stimulated? So when someone is moving his head, causing pressure on the neck, or someone is having a tight collar, or someone has gone to the salon to cut his hair, and if this barber suddenly moves your head, you can suddenly stimulate the carotid sinus. So that is called barber chair sign. So hypersensitive carotid sinus syndrome. Next, vasovagal syncope. Now, vasovagal syncope is a common syncope which normally does not need a pacemaker. But if a vasovagal syncope is bradycardia predominant, where there is significant bradycardia of heart rate less than 40 beats per minute, or there is sinus arrest, then it qualifies for putting a pacemaker. Pacemakers are often needed after cardiac transplantation, and pacemakers are often needed after a myocardial infarction. Can any one of the students tell me which type of myocardial infarction can lead to AV block?
Inferior wall MI?
Pardon?
Inferior wall MI, sir?
Inferior wall MI causes second degree or third degree AV block. Yes. Is it reversible or not reversible?
Reversible, sir.
Pardon?
Reversible, sir?
Most of the time, the AV block that happens secondary to inferior wall MI is reversible. But if it happens in the background of anterior wall MI, then it is prognostically bad. And if there is an AV block in presence of anterior wall MI, the patient mostly needs a pacemaker, remember. Nice ECG. Can anyone tell me what is there in this ECG? You have to tell me.
Sinus arrest, sir?
Yes, tell me. Please tell me. Whatever you see, tell me. Feel free. Feel free to interact. Otherwise, it will be a one-way discussion. So these are basically, this is basically a tachyarrhythmia. It is basically a SVT. And in between, there is long sinus pause. This is a P wave. This you can't make out P wave. This is a P wave. Here there is a P wave. There is an SVT. Then there is a sinus pause. So what is this? What is the disease?
Six sinus syndrome, sir, tachybrady
So
syndrome.
this is a classical six sinus syndrome, tachybrady syndrome. So this is a classical indication of putting a pacemaker. If there is significant sinus pause, if the patient is symptomatic, having syncope, then the patient qualifies for putting a pacemaker. So what are the causes of six sinus syndrome? Most important is degenerative disorders. Besides degenerative disorders, it could be infiltrative disorders like, very common is sarcoids, amyloidosis, and various connective tissue disorders. Besides, there may be some extrinsic factors that can influence the sinus node, like carotid sinus hypersensitivity, neurocardiogenic syncope, or vasovagal syncope. The extrinsic factors that mimic or exacerbate six sinus syndrome: hyperkalemia, hypocalcemia, hypothyroidism, hypothermia. And lastly, different sorts of pharmacological rate controlling drugs that can have effect on the sinus node. The antiarrhythmic drugs, the calcium channel blockers, beta blockers, and some other antipsychotics. So what are the indications of putting a pacemaker in a six sinus syndrome? So documented symptomatic bradycardia, including frequent sinus pause, chronotropic incompetence. Do you know what is chronotropic incompetence? If the patient cannot increase his heart rate according to his activity. So whenever a patient is doing some exertion, ideally, the heart rate should increase. But if the heart rate do not proportionately increase, then that is called chronotropic incompetence. Class 2A indication symptoms not documented. There is asymptomatic patient, but the resting heart rate is less than 40 beats per minute, indication of putting a pacemaker. An unexplained syncope in a patient of suspected six sinus syndrome, or an abnormal EP study. These are all indications of putting a pacemaker in six sinus syndrome. What are the other indications? It could be an AV block, an intermittent or a persistent second degree or third degree AV block. Cardiac pacing should be considered when there is a syncope with asymptomatic sinus node dysfunction, but you cannot establish the relation between syncope and sinus node dysfunction, but still you should think of putting a pacemaker. Second, bundle branch block or bifascicular block. If a patient have a left bundle branch block with syncope, then that is an indication of putting a pacemaker. If the patient is having a bifascicular heart block, say right bundle branch block with left anterior or left posterior fascicular block with syncope, then that is also an indication of putting a pacemaker. If the patient is having a bifascicular heart block with abnormality in EP study, then that is an indication of putting a pacemaker. Or suppose a patient of bifascicular heart block syncope but otherwise asymptomatic, you can put the patient to an Holter or an implantable loop recorder, and if the Holter or implantable loop recorder shows intermittent AV block, then that becomes an indication of putting a pacemaker. So what do you see in this ECG? Anyone? Students? Can anyone describe what is there in the ECG? I know it is MBBS type 1. What happens in MBBS type 1?
Sir, PR is progressively, gradually prolonged, and then
The
there's a drop.
progressive prolongation of the PR followed by a missed P wave.
Yes, sir.
Is this an indication of putting a pacemaker?
No, sir.
Anyone?
No.
MBBS type 1 is not an indication of putting a pacemaker. It could be found in healthy athletes. It could be found in those who have an increase in vagal tone. It can be found in inferior wall MI. So MOBIS type 1 is not a strict indication of putting a pacemaker.